Actually, what we will present is the TICH-NOAC trial. It's a trial on tranexamic acid used for treatment of acute intracerebral hemorrhage in patients who are on these novel oral anticoagulants. These anticoagulants are alternative to the vitamin K antagonist anticoagulants and are increasingly used. They induce a lower number of hemorrhages, but it's not zero. So we still have patients with intracerebral hemorrhage that are on these NOACs. These are mainly patients who get NOACs because of atrial fibrillation or because of lung embolism or venous thromboembolism. When a patient gets a hemorrhage, it may be the same like he would be on vitamin K anticoagulation. This means that there is a severe morbidity, and we would like, or we try, to have a better treatment than the treatment that we have already. So the treatment is actually standard is 4-factor PCC, and in addition we will add the antifibrinolytic drug that is tranexamic acid.
Yes, and to date there are no real randomized trials, controlled trials on this topic. So we don't really have valid data on the treatment, acute treatment of NOAC-associated ICH. And this was the idea to do so, to the best of our knowledge for the first time, to have a randomized controlled trial. And the idea on the tranexamic acid was also based on previous studies on cerebral hemorrhage not related to oral anticoagulation and also not the NOACs, but on spontaneous intracerebral hemorrhage. And the main study published recently, a couple of years ago, was the TICH-2 trial, who looked at this, and which was a large international study, more than 2,000 patients included. And in that study, the main outcome was disability at 3 months. This study was overall negative, but the study did observe some effect on what we call the hematoma expansion in the acute phase, which is the growth of the hematoma. And that is why we, for our study, chose the hematoma expansion to be the primary outcome measure in our study.
Yes, having this in mind, we conducted a study that should treat patients in a randomized way up to 12 hours after symptom onset. So it was an acute stroke study, but with treatment up to 12 hours. And the patients will have either placebo or 2 grams of tranexamic acid, what means 1 gram as bolus in 30 minutes, followed by an 8-hour infusion of a 2nd gram. And it is completely blinded to the investigators, and the compound was purchased and prepared by the University Basel pharmacy, and it was applied within 30 minutes of randomization. But this means that the patient had to consent, or if this was not possible, as patients sometimes are really severely affected, then a deferred consent by an uninvolved physician or confirmation of the willingness to adhere to a trial was given by the relatives. With this, we finally randomized 67 patients. Actually, for ITT analysis, there are 31 patients in the placebo group and 32 patients in the tranexamic acid group. So what we find is that there is still a high amount of hematoma expansion. This means we had almost 50% of hematoma expansion in the same amount in both groups. So for the primary endpoint, there was no effect of the tranexamic acid. The same was also true for the clinical follow-up. So patients that were severely disabled or died was 42 versus 45%. So that's the main result, but there are some secondary predefined analyses where we see that there may be some effect of the tranexamic acid that goes in the same direction like in the large trials.
Yes, we performed these subgroup analyses, also based on the information we had on these previous studies. We looked at clinical demographic measures and defined the subgroup by age and by gender, etc. And regarding the clinical aspects, it was interesting that we did see an interaction between the time from symptom onset to treatment. So the patients that came in fast, there seemed to be some potential effect of the tranexamic acid. And also those treated regarding their acute hypertension, so who had lower blood pressure levels, also showed an interaction between the effect on hematoma expansion. And these results are quite well in line with what has been shown in the other previous studies looking at non-OAC-related ICH. So although we didn't see an effect on hematoma expansion for the overall group, we did find some potentially interesting effects in these subgroups. Also, nowadays in many centers, it's standard of care using the PCC, the prothrombin complex, and about 2/3 of our patients receive this in addition to the study treatment as part of the standard care. So we also looked if there was an interaction between this additional treatment and tranexamic acid treatment within the study, but we did not observe an additional effect on this. This is also an important information clinical-wise.
Actually, the trial was stopped because of exhaustion of funding. But anyway, we were at a stage where we should have had interim analysis, and that's a good point. Now, if we would like to continue this trial, what is likely, we know how we will modify the protocol with the knowledge from the subgroup analysis. So it's a good point to show right now the results of this trial.
Yes, and one additional aspect is that nowadays more and more there are more specific antidotes for reversal of the coagulation effect of these direct oral anticoagulants. In our study, all patients received a factor 10A oral anticoagulants, and there is the specific antidote andexanet alpha, which is currently being investigated in a trial. And one additional subgroup analysis we performed in our study was to implement these eligibility criteria for that study on our population to see if those patients that meet these criteria may show an effect also related to tranexamic acid, and this was the case. So in this subgroup analysis we also found a tendency, and this indicates that the criteria used for these specific studies are probably well chosen, and we will see what these trial results will bring in the near future.